ฮัลโหล1 2 3นะครับท่านผู้เข้าร่วมสัมมนาทุกท่านนะครับในช่วงเที่ยงนะครับหวังว่าทุกท่านคงจะได้รับสาระและความรู้นะครับในเรื่องของศาสตร์และวิทยาศาสตร์แล้วก็ความรู้ทางด้านการแพทย์ที่เกี่ยวข้องกับเรื่องมะเร็งนะครับมากพอสมควรนะครับซึ่งในเซสชันช่วงบ่ายนี้นะครับเราก็ได้แบ่งห้องประชุมเป็น2ห้องนะครับเป็นห้องนี้นะครับแล้วก็อีกห้องหนึ่งที่อีกเรื่องหนึ่งนะครับซึ่งจะเป็นการนำเสนอทางด้านโปสเตอร์แล้วก็งานวิจัยนะครับสำหรับในโปรแกรมในช่วงบ่ายในห้องนี้นะครับเราก็จะเป็นการเสวนานะครับแล้วก็มีการนำเสนอนะครับสิ่งที่น่าสนใจนะครับที่เกี่ยวข้องกับทางด้านมะเร็งนะครับในกำหนดการซิมโพเซียมในช่วงบ่ายนี้นะครับเราได้รับเกียรตินะครับจากท่านวิทยากรนะครับซึ่งจะมานำเสนอแล้วก็มาเล่าเกี่ยวกับเรื่องของสิ่งที่น่าสนใจนะครับเกี่ยวกับด้านศาสตร์ทางด้านมะเร็งนะครับในซิมโพเซียมในช่วงบ่ายนะครับผมขออนุญาตนะครับขออนุญาต Okay, in the afternoon section in afternoon we're gonna have the symposium that about the talk with the guest speakers. From now I would like to introduce you to the Professor Emeritus Khunying Kobchitt Limpaphayom, and the symposium in this afternoon session gonna be about Comprehensive Cervical Cancer Control for Equity in Thailand. Please welcome Professor Khunying Kobchitt.
ขออนุญาตพูดเป็นภาษาอังกฤษก่อนกันแล้วกันนะ Good afternoon, ladies and gentlemen. This afternoon will be the comprehensive cervical cancer detection, which is going to be what we call it early cancer control. And for equity or not, you will decide yourself. How are you going to make it equity or not? First, I would like to start with why do we have to talk about this thing? You should know that in this area, Roi Et province is the birthplace of early cervical cancer control for Thailand. We have about 200 nurses provider who had been trained here in Roi Et, around Roi Et, to detect the cervical cancer by using the visual inspection with acetic acid along with the pap smear. And we have a good referral control which is done by the Roi Et Hospital. And we have a good referral sending center for the patient who has been treated. And most of the time it has been done by our nurse provider. And I think I'd like to give a big hand for all those nurse providers. But I ask you. And I'm sure many sit in here because we have around 200. So anyway, the very first, the first speaker will be Associate Professor Dr. Kathleen Schmeller, who is at present in the oncology unit at MD Anderson. Please, Dr. Kathleen Schmeller, she will speak about the early cancer control, which is her work that she has been doing for the control in the country and somewhere else that you will listen to her. Kathleen, please, I think you're going up to the stage.
Good afternoon. Good afternoon. Thank you very much to the organizers for the invitation to speak today. And thank you especially to Dr. Wachara and also to Khunying Kobchitt for this amazing experience to be here and part of this conference with you today. I'm going to talk about some of our work at MD Anderson and elsewhere with regards to cervical cancer prevention. As we all know, cervical cancer is completely preventable, and no women should be dying of this disease in 2016. Due to the great work of Dr. Harald Zerhausen, the Nobel Prize winner in 2008, and many others, we now know that cervical cancer is caused by the human papillomavirus. It's one of the few cancers that we know the cause of almost every case. We have excellent preventive vaccines now, or prophylactic vaccines, that should be able to completely eradicate the disease. We also have very good screening tests. We have the Pap test. We now have DNA HPV testing. And as you are all very familiar with, we have VIA, or visual inspection with acetic acid. And we have a very treatable pre-invasive phase. So if we are able to find cervical cancer before in the pre-invasive stage, we can treat it with cryotherapy, a very simple procedure, or with a LEAP or conization. And we're very lucky that it takes about 10 years to progress from the pre-invasive stage to invasive cancer. So we have a long time to intervene and treat these women. Just a little bit about the vaccines that are now available. They are recommended for girls, and in the US we are also vaccinating boys beginning at age 9. There are now 3 available, the Gardasil 4, Cervarix, and most recently a Gardasil 9 that covers 9 types of HPV. These vaccines are given either as 2 doses in some countries or 3 doses in others over a 6-month period. They have been shown to be very, very effective in preventing cervical dysplasia and cervical cancer. And they're also very safe. However, the vaccines don't affect disease or infection with HPV that was present prior to vaccination. So it's very important that these vaccines be given to children prior to the onset of sexual activity and exposure to the HPV virus. As you can see here, the countries in orange have introduced a national immunization program for HPV. Again, many in North America, beginning in South America and in Western Europe and Australia. Unfortunately, many countries still have not introduced a national vaccination program against the HPV virus. And so that is one of the reasons that we still need screening. The vaccination, many countries have not yet started a vaccination program. And even in countries like the United States, where we have a vaccination program, we are vaccinating only a small proportion of our populations. In addition, we have 2 to 3 generations of women who are exposed to HPV prior to the vaccines being available. And so in this group, the vaccines are far less effective. And so we will need to have screening for cervical cancer for the foreseeable future. So worldwide, there are about 500,000 new cases and 250,000 deaths annually. In the United States, we have a great success program. Cervical cancer is now about the 14th most frequent cancer among women. Our cervical cancer rates have decreased by about 70% over the last 60 to 70 years due to the Pap test and then the organization of good screening programs in the United States. We have about 11,000 new cases and 4,000 deaths per year. However, we still have very high cervical cancer rates among underscreened women who don't have access to care. So even in the United States, we have very large disparities between the women who have access to health care and screening and those that do not. In addition, in low and middle income countries, cervical cancer is one of the most common causes of death among women because of a lack of access to screening programs. When you look at a map of the world, the countries in red are the countries with very high cervical cancer rates. So primarily in Central America, South America, Africa, Sub-Saharan Africa, and then also many parts of Asia. It's estimated that about 85% of the world's cervical cancer cases occur in low and middle income countries. So cervical cancer has large disparities, both between countries, but also within countries. So as an example, in the United States, I live in the state of Texas, a very big state. There's an area in the southern part of the state called the Rio Grande Valley. It's along the Texas-Mexico border. So we have many immigrants, both from Mexico as well as from Central America, from Honduras, El Salvador, Guatemala, and other countries in Latin America. About 90% of the population is Hispanic in this area. 40% live below the poverty line. And it's estimated that less than 5% of these women, even though they are in the United States, are receiving the recommended cervical cancer screening. So we have very big disparity. And what we know about this area of the state is that the cervical cancer rates are about 30% higher than the rest of Texas. So within the United States, we also have incredible disparities. As I said, in the US, we have significantly reduced our cervical cancer rates, and it's been through a program that involves 3 visits. The first visit, we do a Pap test, and now we also have HPV testing available. If that comes back abnormal, we contact the patient, and she comes back for a second visit. At the second visit, we perform colposcopy, where we place acetic acid or vinegar on the cervix, look with a microscope, and then do biopsies if we see any abnormal areas. We send those biopsies to the pathology lab, and then if they come back abnormal, we contact the patient again to come back for a third visit. It's less than 5% of the patients, but still a significant number of patients. The patients then come back to undergo a procedure to either remove or ablate the precancerous cells. So we do either cryotherapy or a conization or a LEAP. But this requires 3 separate visits, and at each step we need to have a pathologist or a pathology lab involved, and then we also need to be able to communicate with that patient and for them to be able to come back for each of these visits. And although it has decreased our cervical cancer rates significantly, in areas where either these services are not available or the patient is unable to return repeatedly for these visits, cervical cancer rates are increased. What we know about this system, as I said, is that it works very well in high-resource settings, but it has not worked well in low-resource settings, resulting in the big disparities in cervical cancer rates between different countries. What we also know is the availability of pathologists varies greatly from country to country. This slide shows an example of Africa. And when you compare Africa with the UK and the US, the number of pathologists has huge disparities. So in the UK, we estimate that there's about 1 pathologist per 15,000 people. And in the US, there's 1 pathologist per 19,000 people. When you look at this map of Africa, even in South Africa, Botswana, there's 1 pathologist per 200,000 to 500,000 people. And in many countries of Africa, there's 1 pathologist per million or per 5 million people. And this pathologist is not just working on cervical cancer. They have all the responsibilities of the autopsies, all the other different pathology services provided. So the idea that in low-resource settings you could have pathology service to look at Pap tests and at cervical biopsies is not feasible. And again, hence the reason for the very large disparities in cervical cancer rates depending on the region. So what we know is that the current screening and prevention algorithms are not feasible in low-resource settings. The high level of infrastructure, including the well-trained personnel and the pathology services required at each step, is not feasible. And so it has led to a lot of our work looking for simpler, more cost-effective prevention methods. One of the most widely used and successful is visual inspection with acetic acid, or VIA. It's low cost, can be performed by nurses and primary healthcare workers. And then you can combine the VIA with treatment with cryotherapy or LEAP, and then you have the single visit screen and treat approach. So much more feasible for the patients to be able to come just for one visit. There have been some excellent studies, primarily from India, led by Dr. Sankar, the next speaker, and others, that have shown significant decreases in cervical cancer mortality using VIA. However, there is some concerns with VIA because you can have false positive results that can lead to expense and overtreatment. However, it's a very, very successful program, as you know well here in Thailand. We have been very fortunate at MD Anderson to work with Khunying Kobchitt from Chulalongkorn University. She is featured here in the New York Times, probably our most famous newspaper in the United States. And she was featured here for the work she has done here in Thailand with cervical cancer prevention. As you can see, the title of the article was Fighting Cervical Cancer with Vinegar and Ingenuity. So we have been working with Chula for several years now, but in 2014, Dr. Marcelo Del Carmen from Harvard University in the US and I were fortunate to come and to tour Royat and the surrounding areas to learn more about the very successful program you have here in Thailand and how we can work with some of our other partners around the world to replicate what you have done here so successfully. We were absolutely impressed and amazed with the quality of the program here, with the nurses, the administrative officials, the ministry, and how dedicated everyone has been to this incredible program here in Thailand. It really is an example for the rest of the world. So in addition to VIA, another area that is becoming more common is to use HPV testing. So it's a simple swab that is used to test for the HPV virus in women. Again, some nice studies from Dr. Sankar's group that showed a single lifetime screening test with of HPV led to a 50% decrease in cervical cancer incidence and mortality. So again, another very, very great way to screen for cervical cancer. The problem with the HPV test is the cost. It's about $50 to $100 per test. Again, you need a laboratory to do the testing. And then you can have a waiting time of several days or weeks for the results. So very different than VIA, where you get immediate results. With HPV testing, you often have to wait. There are several low-cost rapid HPV tests that are under development, and one that currently exists called CARE HPV by QIAGEN. But again, the cost as well as the wait time can be significant. With the CARE HPV, it's a low cost, about $5 a test, which is still too expensive for most areas to put into their national screening program. The other problem with it is that for it to be that cost, you have to run 96 samples at a time, so it's very difficult when you are not seeing that many patients at one time. However, it has been a great breakthrough, and there are several other tests that are being developed. This is the example of one test that we are collaborating on from Rice University, engineering school in Houston, Texas, where I work. And this is a point-of-care HPV test that is a simple test where you can just get a swab, place it on a piece of paper, and then you will get a result within 10 minutes, positive or negative. The goal for this is for it to be about 10 cents. So there are many groups similar to ours working on such tests that we hope will help to complement the VIA program such as you have here in the future. So the challenges that we have started to look at MD Anderson is how can we make the existing program like you have here in Thailand better? One of the problems with both VIA and HPV is that they have a low specificity, which means you can have false positive results. This, as I said, can lead to some overtreatment and increased costs, as well as some unnecessary concern for patients. In addition, you can have the limited availability of colposcopists and pathologists. So if you have these patients who are positive or it's unsure, it's very expensive to refer them to the next level of care, to either the district hospitals or to the cancer hospitals to do the additional procedures. So we are trying to find ways that in the community clinics we can help distinguish whether it's truly a precancer or not. And so we have some amazing collaborators at Rice University in Texas who have developed something called the High Resolution Microendoscope, or HRME. And this is a novel cervical visualization technique. So it's sort of like VIA with some improvements. It was developed by Rebecca Richards-Cordum at Rice University. And what it does is it sort of replaces the gynecologist or the colposcopist and the pathologist. So it's a device where you can see real-time the features that a pathologist looks at under the microscope. Things like the size of the nuclei, the nuclear to cytoplasmic ratio, the atypia of the nuclei. And the goal really is to eliminate the need for colposcopy, cervical biopsies, and pathology services because they are so limited all around the world, including many parts of the United States. If we could find something that could replace them that was just as effective, we believe we could improve the cervical cancer screening programs. You can see here a picture of the cervix. It's a very, very simple procedure. We place proflavine, which is a liquid similar to acetic acid, onto the cervix. And what it does is it actually stains the nuclei. So it's a very, very cheap material. It's an antiseptic that is used on the umbilical cords of newborn babies and then also used sometimes on surgical wounds. So very, very inexpensive liquid. We place it on the cervix with a Q-tip, and then we apply this small probe. And then what that does is it takes a picture of the cells on the cervix and transmits it back to a computer screen in real time. So you can see here on the left is what normal nuclei look like. They are well spaced, they're small, they're bright. And then on the right side is what an abnormal cervix would look like. So someone with precancerous cells, the nuclei are very crowded, they're much bigger, and look abnormal. And you can see here kind of the progression from normal to inflammation to then areas with a low-grade dysplasia or CIN1. And then as the nuclei are more crowded and more abnormal, you can see CIN2 or 3, which is high-grade dysplasia. And then the last picture is of a patient who had cancer. And you can actually see the blood vessels that you can't see with the naked eye, but with this probe you can see the vascularization. As the tumor forms, it has an increased blood supply, and you can see these small vessels. But the idea is not that the person doing the exam would have to figure out what is normal, what is CIN1. Although those pictures look very obvious, it can still be challenging. So the idea is that the computer will do all the work for you. And so you can see here, this is a patient with a normal cervix. I think my screen froze, I'm sorry. Oh, now it's working. Okay, thank you. Sorry about that. It's good. That's perfect. So you can see here, what happens is we put the probe on the cervix, and then we have a small foot pedal. And once you have the image, you freeze it. And then on the right, you can see the cells, then the nuclei then become outlined in either yellow or red. Yellow is okay, they're normal, and red is any abnormal nuclei. So the computer does this for you in a few seconds. And then it will tell you at the bottom, you can see a red or green bar will come up to see whether it meets the requirement to be high-grade dysplasia or normal. So in this case, it's normal. In this case, again, you see the CIN23. So when there are many, many more nuclei outlined in red, showing that, again, this is an abnormal. So the idea is that the person doing the procedure doesn't need to make that determination. The computer, the image will be taken, and then the computer will run it through the algorithm. And then the screen will flash either green or red, whether that patient needs treatment or not. So it would take not too much training to learn to be able to do this. Far less training than to become a pathologist or a colposcopist. So you can have many, many more to see all these patients. You can see here inside the mobile unit, it has an exam bed, a colposcope, the machine. Again, this is specific for the study, so it's not really the real world, but you can see how, should this be successful, that we could expand it to be in regular use. Travels to very, very rural areas all over Brazil. Some of the areas are more than 1,000 kilometers from the main hospital. And even now, they have a Facebook page where we know at any point where the mobile unit is, how many patients it has seen, so we can keep up with how far they are traveling. And so far, the results are very good. So in conclusion, we're doing many studies with new technologies to try and make cervical cancer screening more effective. But I think it's very important to remember that we can completely prevent cervical cancer with our existing tools and technologies that many of the people in this room have studied and developed. So first, we can't emphasize enough the importance of the HPV vaccine. It's so important for us to vaccinate our children so that we can prevent not only cervical cancer, but anal cancer, oropharyngeal cancer, vulvar cancer, penile cancer in the populations of the future. And then in addition, we have excellent screening tools with VIA and immediate treatment with cryotherapy. As I said, here in Riyadh and in Thailand, you have been the leaders in showing the world that a program can be very, very successful. And back to the idea of equity, you know, a woman should not die of cervical cancer because of where she is born or who she is born to or where she lives. You know, as I said, even in Texas, somewhere 6 hours from MD Anderson, one of the biggest cancer centers in the world, the cervical cancer rates are 30% higher than the rest of the state. And I know you have similar problems here in Thailand and in many other countries. But again, the inequity is, again, the lack of access and the lack of programs that we are able to provide for patients. And for my last slide, I would just like to show a picture of Dr. Khunying Kobchitt. And this is a very special picture to me. There's a doctor, a very famous gynecologic oncologist named Lynette Denny, who's from South Africa. And she is a good friend, and she has done amazing, amazing work in the world of cervical cancer prevention in South Africa. And she says there are many groups around the world and many people trying to work on this problem. And they come and they make very loud noise, and they do a lot of things, but they don't stay until what she calls the last ping. So they come, they hit the drum, they make a lot of noise, and they leave, instead of staying until the very, very last sound. And I think we all know that Khunying Kobchitt is someone who has really always in all her work stayed for the last ping and really done amazing work to make a difference, not just for the women of Thailand, but for the women all over the world by showing the success of the program here. So with that, I will end, and thank you very much for your attention.
Thank you, Kathleen. It's not thank you for my picture. You all hear what Kathleen has said about the cervical cancer prevention from her experience, from the experience that she saw we did in Thailand. We are doing in Thailand, and she gave us a complementary program, the one she did, high resolution, what is M mean? Yeah, HRME. So anyway, we may, in the future, will probably do something correspond and comparable to this in the study. So I think that I leave the question at the end. I would like to ask Dr. Sankarayanan to give us talking for his session. Next one, please. Could you go up? Kathleen, sit down here first. What Dr. Sankar is going to talk is about the integrated cancer registration for Thailand. And this is again, is another field that I have to say that we are not good in doing the registration. But he is the one that doing a lot of registration, and he's been helping us for the very beginning. Dr. Sankar, please.
Thank you very much, Professor Emeritus Khunying, Dr. Kobchitt, for your kind introduction. At the outset, I would like to thank Dr. Kriyanka, the director of the Royat Hospital, the Inspector General of the Health Region 7, which is the region of Royat, Professor Kobchitt, Dr. Vachara, and many colleagues for the kind invitation and hospitality. For me, it is always a pleasure and privilege to come to Thailand and interact with all of you. And I have always been touched with the warmth, the friendliness, and with the hospitality that you receive others. And it makes oneself at home in your beautiful country. Thank you very much. What I'm going to do in the next 30 or 40 minutes is to quickly review what we have learned from cancer registration in Thailand and put this in perspective with what we know in disease control, in cancer control, drawing some examples from Thailand as well as from regional countries, how we can improve cancer registration, cancer information collection, and how we can use this in disease control, in cancer control, how we apply what we learn and how we use it, and at the same time, how we improve collection of data, which is very fundamental in disease control, in monitoring any disease control. This is what I would like to do in the next 30 minutes or so. Quite often in cancer control, people don't realize how much cancer registration has contributed to our understanding of cancer in the last 50 years, and on the burden of disease, the pattern of disease in different parts of the world, which is enormous. And this has been possible because of the work of many people, the clinicians diagnosing and cancer and documenting this in very good medical records, the medical record technicians keeping the medical records, the cancer registry personnel abstracting and documenting the data and analyzing the data, complete data, and publicizing that. So from that perspective, cancer registration is defined as a continuing systematic collection of data on the occurrence and characteristics of cancers with the purpose of helping to assess and control the impact of cancer on the community. Without cancer registration, we would have come out with fantastic figures for cancer. People will say it is millions and millions and billions. Now we know the exact figure in many parts of the world thanks to cancer registration. So the cancer registry is a continuing activity. Without this continuing activity, you won't have an accurate information on cancer. Those countries which have this type of accurate information do very well in cancer control because they know where they are at what is really happening to the cancer spectrum. So this is very critical. So among the cancer registries, the cancer information systems, you have the population-based cancer registry, which provides the information on cancer in the community, in regions, in countries, sub-regions. This is the one which gives the reliable data on cancer incidence, trends in cancer incidence, and outcomes like population-based cancer survival. And the population-based cancer registries in small countries like Singapore, Oman, or Kuwait, Taiwan, and places like that covers the entire country. In very large countries like India, China, Philippines, it is not possible or it is not necessary to cover the entire country. You can have small regional registries, and from the regional registries, one can project for the entire country. And in Asia, Thailand has been one of the pioneering countries in establishing sentinel cancer registries in places like Chiang Mai. Chiang Mai is one of the longest standing cancer registries in the developing world, along with China, for example, Shanghai, very many years, Singapore for the last 40 years, Kuwait, and India, for example, Mumbai and Chennai for many years, and along with some of the very historic registries in Latin America like Cali in Colombia. So Thailand has done reasonably well, but there is an enormous scope to improve how the data are validated, how the data are pooled, and how the data can be used. The National Cancer Institute in Bangkok has been a pioneering cancer institution in the world, which has consistently supported cancer registration in Thailand, constantly trying to improve the quantum and the quality of the validity of the data collected, with continuing training and empowerment of the cancer registrars. That is really commendable. I mean, Dr. Pecharin and in the audience, Dr. Sulipon is there, and many of the colleagues from the Cancer Institute are there. So this has been, and stalwarts like Dr. Khunying, Kobchitt, and others in this country, senior clinicians, have consistently supported cancer registration across Thailand. So in short, the cancer registries are extensively useful in performing a situation analysis to describe what is the pattern of cancer in the country, which are the common cancers, what is the cancer burden, what is the current incidence rate, what is the prevalence, what could be the future projection in case nothing happens in terms of prevention and control, and what is the pattern of care, what proportion of people are diagnosed in what stages, what proportion of people complete treatment, and how people survive. So all this can be gleaned provided the cancer registries are complete and collect valid information. And they are very useful in surveillance, in monitoring and cancer control. Monitoring how the cancer patterns emerge, whether the cancer pattern changes, the incidence rates changes. What are the trends in pattern of care? For example, one of the very useful parameters in cancer control is the proportion of people completing prescribed course of cancer treatment. And without treatment, you don't achieve the outcomes that you desire. So this is just an example. What is the trend in early stages, the proportion of early stages, for some of the very common cancers like breast cancer, cervix cancer, head and neck cancer, and things like that? So the trends in clinical extent of disease, the trends in treatment patterns, and the outcomes in terms of survival. In fact, the population-based cancer registries provide a very important indicator along with the incidence and mortality, which is known as the population-based cancer survival. The population-based cancer survival reflects the average prognosis of a cancer patient in a given setting. For example, in the city of Chiang Mai, how a cervical cancer patient survives, or how a breast cancer patient survives. In Chiang Mai, there are public hospitals and private hospitals with varying expertise. There is varying natural histories of disease. Some people complete treatment, some people do not complete treatment. The quality of treatment varies. So the population-based survival, since it studies the survival information of all the cancer patients in a given population, it is the average of the survival experience, which is a very important indicator for cancer control. For instance, about 20 years back, when they studied cancer survival in Europe, they found Britain had the lowest cancer survival among Western European countries. It was such a shock for the British Ministry of Health, which led to reform of the cancer control program in Britain, reformation in NHS, and it came out with very strict criteria for access. For example, the Western European countries at the moment have benchmarks for cancer treatment. A patient is suspected with cancer. Within 30 days, this patient should have reached a specialist consultation. And from the diagnosis, date of diagnosis, within 30 days, treatment should have been initiated. These are the benchmarks. For example, at the moment, Scotland achieves 80% of the patients from the date of clinical suspicion in primary care reach a specialist. And about 75% of the patients from the date of diagnosis, the cancer-directed treatment is initiated. All this information comes from the registries there. Now, coming back to Thailand. The National Cancer Institute in Thailand has been coordinating cancer registration across Thailand, trying to pool the data, trying to improve the data constantly. And they publish regularly a volume called Cancer in Thailand, which is a very important reference material for cancer patterns in this country. The Thai cancer registries regularly submit data to cancer incidence in 5 continents, which is a very important publication by the International Agency for Research on Cancer, which is published every 5 years, where the editors look into the quality of the data and include in it. So based on this information, we can glean which are the first 5 most common cancers in Thailand. Among men, liver cancer, lung cancer, cancer of the colorectum, prostate, and leukemia, with the age standardized incidence rates given there. And for cancer mortality, the 5 common sites are liver cancer, lung cancer, cancer of the colorectum, leukemia, and esophagus. In fact, these 5 cancer sites account for almost 60% of the cancer burden in men, with the message, if we can control these cancers, it will have substantial impact on overall cancer pattern. And among women, the 5 most common cancers are breast cancer. With socioeconomic improvement, breast cancer is increasing. Cancer of the cervix, which is the second most cancer, as Kathleen said. Lung cancer. Thailand is one country among the first 5 cancers among women lung cancer figures. This is an important area of research. Of course, liver cancer and cancer of the colorectum. And mortality, if you look into mortality, lung cancer and liver cancer account for the first 2 places among the most mortal cancers. followed by breast cancer, cervix cancer, and colorectal. And from this very simple diagram, one can understand, how the cancer registry data can be used to control some of the major cancers. And then the cancer registries in Thailand has given us a handle to estimate the cancer burden for the total Thailand. So these are sentinel registries, Chiang Mai, Songkhla, Khon Kaen, Lampang, Bangkok, and all those places from the projections. And if you look into the projection, currently, every day, for every 6 minutes, one cancer patient is diagnosed in Thailand, about 350 cancer patients a day. That is the rate of diagnosis in Thailand at the moment, which will substantially increase by the year 2030 unless we have dramatic control measures inbuilt in. This is a very important piece of information which helps how we can plan for cancer treatment services, cancer diagnostic services, palliative care services, and things like that. This can be taken into account in national planning. So this is among women. It also shows how the cancer pattern, for example, in 2015, we have around 64,000 cases, which will increase to around 87,000 cases in 2030, unless we dramatically control some of the major cancers. So these are very reliable projections because Thailand has population-based cancer registration in sentinel sites. Suppose you go to the Democratic Republic of Congo in Central Africa, which is one of the largest countries in the world. We have absolutely no clue on cancer patterns because there is no cancer registries. The surrounding countries have no cancer registries. So we have to go to places like Nigeria or another place to project for Congo. So this is not the situation for Thailand. So we have, but still there is a good scope for further improving the data. Now I am going to go to some specific cancer sites. A number of graphs are there, but we can learn from them. Thailand has a very high risk of liver cancer. And specifically in Thailand, you have two major cancers, the cholangiocarcinoma. I think we are sitting in the capital of cholangiocarcinoma in the world. In a very high incidence rates, almost around 60 to 70 per 100,000. Khon Kaen, Royat, these are all the capital of cholangiocarcinoma. And the rest of Thailand has a very high risk of hepatocellular carcinoma along with China and other countries. If you look into the trends, Chiang Mai is one of the star registries in Thailand because this is the longest standing cancer registries in Thailand from which one can glean the incident trends. And if you see the picture here, in Khon Kaen, the Khon Kaen Cancer Registry data currently indicates liver cancer is declining at a rate of around 2.5% per annum, the annual percentage change. This is a good news. And this could be due to the general improvement in health life and education on avoiding eating raw fish and other measures which have been taken. But with more intensive education, with more intensive measures, health education measures, this decline, this drop, the annual percentage change could be increased to 5%, 10%, something like that. And hepatitis B vaccination is one of the very important interventions for future liver cancer prevention. Actually, hepatitis B vaccine was invented in 1982, the plasma-derived vaccine, and the recombinant vaccine was invented in 1989. Taiwan is the first country in the world to introduce hepatitis B vaccination as part of the National Immunization Program in 1987. At the moment, Taiwan is documenting a 75% decline in hepatocellular carcinoma in those who are aged less than 25 years who have received vaccination over the last several years. This is the first country to document a reduction in liver cancer incidence. And such trends are slowly emerging in places like Shillong and Singapore. And it is very important Thailand now examines, because Thailand has a very high coverage for hepatitis B vaccination. There is a very good rate of coverage of the newborn babies, the delivery, the birth doses. And Thailand has decreased the hepatitis surface antigen prevalence to less than 2%, which is the benchmark which has been put by WHO for an effective hepatitis B vaccination program outcome. So it is time now, because Thailand is the second Asian country to introduce hepatitis B vaccination. If you look into the introduction of hepatitis B vaccination in national immunization programs, the vaccine was invented in 1982, first introduction in 87. But until 2000, only 4 developing countries ever implemented hepatitis B vaccination, and it became a Gavi-eligible vaccine in 2000. And 2004, 50 countries introduced this thanks to Gavi assistance. And now in 2016, we have 184 countries with hepatitis B vaccination as part of the national immunization program. This is a very, very important public health intervention, along with control measures for hepatitis C. Now coming to lung cancer. Lung cancer is a major cancer in Thailand. Actually, if you look into the trends in lung cancer incidence from 3 long-standing registries from where data are available, I would say this is reasonably a good news. It is not going up as it is going up in China or in Indonesia. The rates are fairly stable. And Thailand is one of the countries which have been very active in the introduction of FCTC measures. And this is one country where the retail taxation now is around 70% of the total price. And with several of the measures which are stipulated in the WHO FCTC being implemented in Thailand. This is fairly a good news for Thailand. And in fact, at least keeping the lung cancer rates as of now with a slow decline or a rapid decline in future is one of the very important things. If you look liver and lung cancer survival in Thailand, we have reliable data. It is less than 5% at 5 years. So these are totally preventable cancers. And look at this. This is Thailand. You can see the Thai results. This is the average, which is very low, because lung cancer is not something that you can win by treating, but you can win by prevention. Now, colorectal cancer. When breast cancer is increasing, colorectal cancer also follows suit. It increases. This is a lifestyle disease. All over the world, people are expanding horizontally with very little physical activity. People don't walk, people don't do household activities. And the dietary patterns have changed. And even in Thailand, you can see Kentucky Fried Chicken and McDonald's and frequented by youngsters. So there is quite a bit of a Western sedentary lifestyle which is catching up, and colorectal cancer has a direct correlation with the so-called sedentary lifestyles. And all the cancer registries in Thailand are recording something like a 2.5% annual percentage increase in colorectal cancer incidence. This is something which needs to be tackled. Traditionally, Asia used to be, along with Africa, one of the lowest incidence regions for colorectal cancer. 40 years back, when Singapore got independence, when the first registry data came in, colorectal cancer practically never existed. The same case in Japan, in South Korea. Now, among men in these countries, colorectal cancer is the #1 cancer. So look at the transformation in 40 years. So all Asian countries are prone to this transformation. So effectively preventing such an increase in colorectal cancer incidence makes considerable sense. And this is true for Thailand, Kuwait, India, and all those big countries, countries in the Asian region. And if you look into the colorectal cancer survival rates, you see Thailand. Thailand is on an average for colon and rectum. Across Thailand in different regions, the survival rates vary between, say, 30 to 40%, because most of the colorectal cancers are diagnosed in advanced stages, and then treatment is quite intensive, and the treatment outcomes for colorectal cancers, regionally extended colorectal cancers, are dismally poor in spite of all the advances in treatment, like adjunctive treatment. And this is very instructive. We can see this pattern for almost all treatable cancers in developing countries. What we have shown here is two groups of countries, Singapore and Turkey, as more developed health services, Thailand, India, and Costa Rica as less developed health services. What it shows is the survival experience of early cancers, colorectal cancers, in Thailand, India, and Costa Rica, and places like that, exactly overimpose the survival experience of regionally extended colorectal cancers in Singapore and Turkey, implying there is considerable need for infrastructure in health services, early detection, and completion of treatment and provision of adequate treatment. And this is really telling. The survival experience of the so-called early cancers in these less developed countries overlapping the survival experience of locally advanced colorectal cancers in Singapore and Turkey. You will see this pattern in almost all cancers. So, the National Cancer Institute in Bangkok few years ago, seized by the situation, wanted to evaluate how can we introduce colorectal cancer screening in health services in Thailand. And Sulipon and colleagues, Dr. Thirawud and colleagues in the National Cancer Institute, along with the health authorities in the Lampang province, introduced a colorectal cancer pilot project, screening project in Lampang district, Lampang province, as a prelude to national expansion by introducing colorectal cancer screening by fecal to vocal blood testing through the primary health centers, reaching the population, establishing colonoscopy services in Lampang province, and then seeing whether it is feasible to introduce colorectal cancer screening in Thailand. Fortunately, the epidemiologists have not confused the realm of colorectal cancer screening. Colorectal cancer screening, things are mostly very straightforward. Whether you use colonoscopy screening or fecal vocal blood test screening, you do it properly, you have outcomes there. But in Thailand, with a very, very limited capacity for colonoscopy screening, we cannot go by that route. So the route which was taken was primary screening with a single fecal vocal blood testing, immunochemical testing, followed by colonoscopy triage of those with positive tests. And in fact, over a 2-year project, it was shown almost 60 to 65% of the invited people participated in the colorectal cancer screening with a test positivity rate of 1.2%, and about 75% of the screen positive persons went for colonoscopy. The colonoscopy capacity was built in, and some of the parameters like the detection rates of adenoma, the detection rate of advanced adenoma, and colorectal cancer, and everything was documented, and the population-based cancer registry and active surveillance in Lampang information collection, and the program was supported by an effective database which all helped in the evaluation of this program. And when we compared this outcome from the Lampang project in terms of colorectal cancer detection rates, adenoma detection rates, advanced adenoma detection rates. Advanced adenoma is like CAN3. If you detect 50 people with advanced adenoma and treat them, you prevent 25 invasive colorectal cancers in the next 10 years. They were all comparable to the pilot projects which were implemented by Australia and UK before they expanded as a national program. So, in fact, through this program, the National Cancer Institute coordinated this and the Lampang health authorities worked on this. Thailand showed it is feasible to introduce colorectal cancer screening through primary health services in Thailand, and it is feasible to sustain. In fact, the population-based registry in Lampang now will provide what is the negative predictive value of a negative fit in Lampang. What has been the validity of a negative colonoscopy? What proportion of people with a negative colonoscopy developed colorectal cancer in the next 2 or 3 years? So a lot of input information and outcome information will emerge from this program. So this is a good example how an intervention is actively supported by a proper information collection which are provided by the program database as well as by the population-based cancer registry. Now coming to prostate cancer. In fact, the incidence rate of prostate cancer is increasing. This is partly because of the availability of opportunistic PSA testing. And this is one disease we will be very dogmatic to say the government should resist from introducing active PSA screening for prostate cancer, because we will end up with considerable overdiagnosis, and the health services will be flooded by the overdiagnosed prostate cancers, which will take away the possibility of prompt treatment for more life-threatening cancers. So this is one area where the WHO very clearly recommends that prostate cancer screening should not be implemented. Okay? So essentially, the philosophy in prostate cancer control is investigating symptomatic men and then managing them as and when symptoms appear and depending upon the stage of the disease. Now coming to breast cancer. Due to lifestyle changes, breast cancer is on the increase. In almost all developing countries, it is increasing at a rate of 1 to 4% per annum, the annual percentage change. If you look into Thailand, it is increasing at a rate of 2 to 4% per annum in different regions of Thailand. There's a steady increase in breast cancer. In fact, in women's cancer control, cervix cancer declines, breast cancer goes up. A comprehensive women's cancer control should aim to keep breast cancer at least stable without increasing and then declining cervix cancer. In fact, we would like to have both the cancers declining, but at the moment we do not know how to prevent breast cancer. And therapeutic supplementation by tamoxifen is not effective for breast cancer prevention. That has to be very clear. If you pool all the randomized trials of tamoxifen chemoprevention, it doesn't have any impact on estrogen negative breast cancers. It has no impact on breast cancer mortality. And in fact, the benefits in terms of a declining estrogen receptor positive breast cancers is compensated by side effects like thromboembolic disease and fractures and those side effects. So that is not the way to go about. So what is the way to go about? And then looking at the survival from breast cancer, I would like to mention at the moment, if you go to South Korea, the 5-year survival of breast cancer is around 96%. In Singapore, the 5-year survival from breast cancer is around 90%. Then you go to India, the 5-year survival from breast cancer is 40%. And in Thailand, the best 5-year survival rates for breast cancer is in Chiang Mai, which is traditionally a long-standing program on breast clinics and breast cancer detection in hospitals, where it is like 70%. But in average in Thailand, the breast cancer survival varies between 57 to 66%, which is on the moderate side, okay? And then you look into some of these places like the Gambia in West Africa, the 5-year survival from breast cancer is 8% because there is literally no treatment available for breast cancer other than surgery. So it all reflects breast cancer. The single most important approach for breast cancer control is early detection in stages 1 and 2, preferably less than 2 centimeters, and providing basic treatment. That is currently the means of controlling breast cancer. So how we do that? And again, just like colorectal cancer screening, we are comparing the survival experience of localized early breast cancers and advanced breast cancers in Singapore and Turkey with that of India and Thailand. And here again you see the survival experience of the locally advanced breast cancers in Singapore and the survival experience of localized early breast cancers in India and Thailand and Costa Rica superimpose. Again showing the inefficiency of health services to diagnose cancers early, to provide prompt treatment, and make that most of the people complete treatment in a prescribed period of time. So this is very important. I think it is very important our ministers of health, our policy makers in our countries take notice of such outcome data. Just like the Europeans did it. East Europeans, they think the survival outcomes are poor, so trying to improve. Britain is trying to improve. So this is important. So now coming to the question of how we early detect breast cancer. is mammography screening is the way forward. I think countries like Thailand, India, in many Asian countries, many Latin American countries don't have the capacity for screening mammography. Screening mammography requires substantial resources. If you look into one of the most organized mammography screening programs, that is UK, they have something like 7 million women in the target population, and they have 80 breast units which do the mammography screening. Each breast unit equipped by 2 mammography equipment, 2 breast surgeons, 2 radiologists, a pathologist, and about 6 to 8 mammography technicians, 6 to 8 breast nurses. Such an infrastructure is unaffordable in countries like ours. And again, mammography screening is quite controversial in the sense that there is substantial overdiagnosis. I think the current estimates of overdiagnosis is anywhere between 10 to 30%, depending upon who looks at the data. So mammography screening is useful, but at the moment it is not feasible, it is not cost effective. So the next best option is to detect breast cancer by physical examination of the breast. There have been 3 randomized trials which looked into breast physical examination. The first randomized trial in Philippines failed because people who have been diagnosed, who have been screened positive, were not investigated properly. Only 30% of them complied with diagnosis and treatment. At the moment, there are 2 important trials in India, one in Mumbai, a randomized trial, a cluster randomized trial comparing clinical breast examination offered by nurses at 2-year intervals to a population in the slums, 75,000 women, and another 75,000 women randomized to the control group receiving usual care. This important randomized trial showed a few years ago it is possible to stage shift. A significantly higher proportion of breast cancers in the intervention group are diagnosed in early stages, in stage 1 and 2. For all practical purposes, if you detect a breast cancer less than 5 centimeters and provide effective treatment, the case fatality rates and survival rates are similar. So this is a very important message. And diagnosing a breast cancer less than 5 centimeters is feasible with the hands. And there is a need for substantial ability within health services for providers to take breast physical examination seriously and use this for early diagnosis of breast cancer. And once somebody is diagnosed with a suspected breast lump or a breast symptom, the next step is a diagnostic imaging. From that perspective, to have capacity for diagnostic mammography and diagnostic ultrasonography. Diagnostic mammography is very different from screening mammography. Diagnostic mammography is a very important diagnostic investigation in people with breast lumps. And then the capacity within health services to do fine needle aspiration, as part of what we call as a triple diagnosis, a physician clinical examination, diagnostic imaging, in women above the age of 40 years, diagnostic mammography, in women below the age of 40 years, diagnostic ultrasonography, followed by fine needle aspiration cytology, is a very effective triaging technique for those with suspected breast symptoms. And in fact, there is another randomized trial in southern India, in Trivandrum, conducted by colleagues at the Regional Cancer Center, where again about 130,000 women have been randomized to clinical breast examination once in 3 years versus routine care plus breast awareness in the control group. And actually, I wanted to show some interim results. If you look into the case fatality for stage 1 and 2, both in the control group and the intervention group, it is extremely low. In fact, for stage 1 and 2, the 5-year survival rates in the control group as well as in the intervention group are around 94%. This is the 5-year survival rate, meaning that if you detect disease less than 5 centimeters, even with movable nodes, 2A or 2B disease, it doesn't matter, provided you have basic surgery, basic adjuvant therapy, and the possibility to biologically categorize the tumors, whether they are estrogen receptor positive or negative. And quite often, we wouldn't go to the extent of looking into the HER2/neu receptors, because once you look into it, and if it is HER2/neu positive, many health services do not have the capacity to provide Herceptin. Okay? So such issues are there. So this is a very important lesson. Actually, in this trial, again, the clinical breast examination substantially early detects breast cancer. So probably for breast cancer, an approach, and a very effective approach, is to create breast awareness in the population, providing sufficient diagnostic capacity in primary care for clinical breast examination, and providing sufficient diagnostic capacity for diagnostic imaging and fine needle aspiration cytology, and the possibility to access treatment within 30 days from diagnosis for breast cancer, and the possibility for health services to do estrogen receptor immunohistochemistry, so that people who are positive on estrogen receptor receive tamoxifen or anti-estrogens, other anti-estrogens, and then those people who are amenable for chemotherapy receive adjuvant chemotherapy and things like that. So these are very basic package. We are not talking about very advanced forms of targeted treatments. We are talking about affordable chemotherapy and affordable hormone therapy, along with surgery, which is the workhorse in breast cancer treatment, along with adjunctive radiation. Now coming to cervical cancer. I think my task has been made much simpler by Kathleen, who talked extensively about cervical cancer prevention using screening. To simply put the fact that cervical cancer is the most eminently preventable cancer, but not yet prevented. Thailand has a long history of providing cervical cytology screening for many years. And in fact, when we evaluated the cervical cytology program with the data provided by the National Cancer Institute in Bangkok, we could confidently say at least 80% of the people in Thailand have received at least a single smear. And a lot of opportunistic smears are being taken in Thailand for several years. But we haven't seen a considerable reduction in cervical cancer incidence in Thailand, probably because of various issues. And Dr. Kobchitt and colleagues, they were pioneers in introducing a VAA screen and treat program in Thailand, which could be introduced through the health services. So screening is a very important intervention. There is a declining trend in Thailand, and it is declining at a rate of 3 to 4% per annum, which could be partially due to screening and partially due to improved reproductive health, reduced parity, socioeconomic improvement, and all those features. And in fact, if you see, cervical cancer is potentially one could eliminate cervical cancer. With the current intervention, elimination is possible. Elimination is zero incidence of disease, but the interventions have to continue. In fact, you would be surprised to hear about 3 months back, a group of Latin American countries have launched a political initiative called Eliminate Cervical Cancer in South America, in Latin America. A Latin America free of cervical cancer, that is the political slogan under which they are investing. I think this is a very noble initiative. Whether they eliminate or not, this is the first time a group of countries are coming out saying, oh, eliminate cervical cancer in South America. I think we should be all saying, eliminate cervical cancer in Asia. I'll come to that in a moment. Socioeconomic development, women's awareness and empowerment, and these are social vaccinations. And in fact, the reductions that we are seeing in many countries are mainly due to this at this moment, in those countries, without cervical cancer screening. And in fact, strangely, in many countries, people use this as a ploy to block specific intervention measures like HPV vaccination and screening. People will say, oh, cervical cancer is declining, why bother? It's a women's gender issue. It is a great inequality issue. The greatest problem I find is there is no women's constituency which comes and argues for that. There is a women's constituency for breast cancer control. Where is the women's constituency going and talking to political parties? Put this in your national agenda, in your election agenda, in your political declaration. So this is dramatically lacking because of the dilemmas associated with cervix cancer. This is very strange. I think this should not be used as a ploy to prevent specific intervention measures, but it is a very great advantage because already declining rates could be substantially declined by introducing specific interventions like HPV vaccination and screening. So that is the message that we should glean from this declining rates in cervical cancer incidence. I mean, at the moment, there is no doubt HPV vaccination is a very safe and effective intervention. There is substantial clinical trial data, although the data comes from predominantly industry-sponsored clinical trials. But there are other publicly sponsored clinical trials, for example, the Costa Rica vaccine trial and the vaccine trial in India. These are all in the public domain, which clearly shows the great potential of HPV vaccination in preventing cervical cancer. So there is no doubt, all this misinformation which is going on, on the safety is unfounded. And in fact, very recently, based on data coming from studies in Costa Rica, India, and Europe, WHO declared that 2 doses of vaccine is equivalent to 3 doses of vaccine in those below the age of 15 years. And the 3 doses are recommended for those above the age of 15 or immunocompromised individuals. This is something which is substantially contributory to the feasibility of introducing cervical cancer vaccination programs in national immunization programs. Kathleen showed the map of the introduction of national programs in HPV vaccination in 2014. This is the situation in 2016. We are in a happy situation now at the moment. There are 80 countries in the world which have introduced HPV vaccination as part of the national immunization program. In fact, it took almost like more than 22 years for 50 countries to introduce hepatitis B vaccination in national immunization program, despite all the bad publicity, misinformation campaigns and things like that. It is heartening to note that 80 countries. And the American region is very much on the forward. In fact, in the continental South America, with the exception of Bolivia and Venezuela, all the countries have introduced HPV vaccination. In the American region, 7 out of 8 girls aged 11 to 13 years have access to HPV vaccination as part of the national immunization program. This is predominantly because of a joint procurement of the vaccine by the Latin American countries through the PAHO procurement mechanism. They all joined together, bulk purchase. So at the moment, the Latin American countries are purchasing vaccine at a unit cost of about $7.99. So this shows the political commitment. Even Africa is doing very well. There are national programs. The entire country is covered in Botswana, South Africa, Uganda, and Rwanda by the governments through the Gavi assistance or national procurement. And about 19 countries have introduced pilot programs as a prelude to national expansion. The continent which is lagging behind is Asia, despite contributing 70% of the cervical cancer burden. In Asia, if you call Israel as an Asian country, Israel, United Arab Emirates, Bhutan, Malaysia, Brunei Darussalam, Japan, where the programs is in doldrums, are the only countries which have, and Uzbekistan are the only countries which have introduced human papillomaviral vaccination. And next year, South Korea is introducing, and Sri Lanka is introducing. And Nepal and Bangladesh have introduced demonstration projects in 2 districts as a prelude to national expansion. In China, the vaccine has not even been licensed for private practice. In India, there has been considerable controversy, and only very recently we have succeeded in convincing 4 provincial governments to introduce HPV vaccination from next year. So in Asia is lagging behind dramatically. And in fact, the 2 model programs for HPV vaccination come from Bhutan and Malaysia. Bhutan was the first low middle income country in Asia to introduce HPV vaccination in 2010. And when they announced they will introduce, the vaccine was suspended in India in clinical trials. The Bhutanese hesitated for a month. They constitute a high-level committee and then made a decision to go ahead. The pilot vaccination in 2010, national introduction in 2010, catch-up vaccination in 2010, and yearly they are vaccinating through a school-based program with 95% coverage for the third dose. Malaysia is the first Islamic country to introduce HPV vaccination in a very carefully considered plan with very well-planned education program, sensitizing people, the religious establishment, and the vaccination was introduced in 2011, and they switched over to a two-dose vaccination, and they have coverage exceeding 95% for the second or the third dose. These are some success stories. Now, cumulatively, more than 350 million doses of HPV vaccination has been administered with an excellent safety record. And in fact, the WHO, the Global Safety Assessment Mechanism, comes out with a statement, annual statement, taking into consideration the safety data from national programs. And this is, you can refer this in the net. And actually, we are seeing the impact of HPV vaccination in some of the early introduction countries like Australia, Denmark, Norway, Canada, and all those places. You know, this is a recent data from Sweden, where in the vaccinated cohorts, in girls who have been vaccinated below the age of 17 years, well before sexual debut, there is almost a 75% reduction in histologically proved CAN2+ disease. This is very, very interesting. And if you take CAN3, which is the real precursor for cervical cancer, there is something like an 84% reduction in histologically confirmed CAN3 in those girls who have been vaccinated below the age of 17 years. And in fact, the observational data coming from countries is a very strong indicator. Even in those girls who have received a single dose, the protection is substantial. And in fact, some of the single dose data coming from Costa Rica and India are very convincing. The protection in terms of persistent infection, high-risk HPV infection, is exactly similar to 3 doses or 2 doses. So I think there is some very important research outcomes are in store for HPV vaccination. And this is an important strategy one shouldn't hesitate to introduce. I think for Thailand, this is very critical. I believe cervical cancer can be eliminated in Thailand. At least you can show the elimination in 20-year-olds, 30-year-olds, and 40-year-olds in 3 to 4 decades if we introduce vaccination at the right earnest. And in fact, one of the pragmatic policies to introduce vaccination and screening is to vaccinate 11 to 12-year girls, but at least provide a single screen at the age of 35 or 39 with HPV testing or VIA and whatever it is, and then repeat it once in 10 years or 5 years if resources permit. This is one pragmatic way of introducing a package of vaccination as well as screening. Now, coming to another thing that one shouldn't do. This is a good example of one shouldn't do. Thyroid cancer is on increase. In the United States, Europe, everywhere it is increasing. But we have a great lesson to learn from South Korea. And this lesson comes because they have an effective information system to capture what is happening. This is the overall cancer incidence rate in South Korea. The overall cancer incidence rate in South Korea is increasing at a rate of 5% per annum. And it is almost doubled in the last 20 years. Why? And if you take thyroid cancer, there is nothing which is happening. And look at the trends in cancer among women. The thyroid cancer rate has substantially increased over the last 10, 15 years. You know why? When the women go for breast cancer screening, they do ultrasonography as well. And they do ultrasonography of the neck and pick up all the silent nodules. And once you pick something, then you investigate them. And these are all very small papillary cancers which will never become symptomatic in lifetime. When you detect something, then you do thyroidectomy, supplement with thyroxine. So this is a harm of an intervention which one should not be doing. This is very, very important. And look at this, the age-specific incidence rate of thyroid cancer, the age-specific incidence rate of breast cancer, because there is breast cancer screening in South Korea. There is ultrasonography and there is mammography, and overuse of ultrasonography of the neck leads to overdiagnosis of thyroid cancer, inducing unnecessary treatment. If you look 5-year survival of thyroid cancer in South Korea, it is 120%. If any cancer, there is more than 100% survival, you are overdiagnosing disease, okay? So this is something one should not do. So the information systems not only show benefits, but what one should not be doing. Finally, I think I'll finish in the next 5 minutes. Tongue cancer, mouth cancer, head and neck cancer, very common in the Asian region due to tobacco habits predominantly. And head and neck cancer is one cancer, despite all progress in treatment, the 5-year survival rate is fairly low. And look at for tongue cancer as an example in Thailand. It is like 24 to 33% in different regions, very low survival rate. You cannot improve. Because in head and neck cancer, as soon as the disease starts involving the lymph nodes or the bone or cartilage, whatever you do, 5-year survival seldom exceeds 20%. If it involves bone and cartilage, less than 10%. Lymph nodes are involved, even with heroic block dissections, the 5-year survival doesn't improve. Adjunctive treatments do not contribute to increased survival. But one thing which works in head and neck cancer, particularly mouth cancer, is oral visual screening. It's a very simple screening test, visual examination of the mouth. Identify those people with oral precancerous lesions and intervene. You can reduce the incidence of mouth cancer, reduce mortality. So, along with tobacco control measures, introducing a very simple screening test in the health services through which oral cancer could be controlled. And finally, I wanted to touch upon a group of cancers which people never talk about. Childhood cancers, lymphohematoid neoplasms. This is a major disease entity in cancer. At the moment, we don't know how to prevent them. The only way you can control lymphohematoid tumors is providing centralized treatments, quality assured treatments. Whether it is childhood cancer, lymphoma and leukemia, multiple myeloma, they have to be managed with specialists in specialized centers. It cannot be managed decentralized. Management is very important, driven by nationally accepted evidence-based treatment policies. I chose the example of non-Hodgkin's lymphoma from Thailand. Like in many countries, non-Hodgkin's lymphoma incidence is increasing at a rate of 1 to 2% per annum, the annual percentage change. And this is a very lethal cancer. In non-Hodgkin's lymphoma and lymphoma, generally in lymphohematoid neoplasms, the biological categorization of the tumors using immunohistochemistry is very important. For example, in non-Hodgkin's lymphoma, the low-grade tumors can be managed very conservatively with very prolonged survival. But on the other hand, the high-grade tumors, which can be identified through specific immunohistochemistry, have to be managed very aggressively in centralized units. Otherwise, the treatment outcomes in such cancers are very dismal. So both in women and men in Thailand, it is increasing. This is the 5-year survival from non-Hodgkin's lymphoma. In fact, if you look Thailand, it varies between 28 to 47%. Thailand is one of the countries where this battery of the 28 immunohistochemical markers are available in most laboratories, which substantially contributes to treatment outcomes, in deciding who gets aggressive treatment, who gets targeted treatments, and all those things. This is just an example. This applies to leukemia, this applies to childhood cancers, and this applies to Hodgkin's disease. But this is a very important group of diseases which we cannot ignore. And this is again, as you see, compared to Singapore and Turkey, the survival outcomes in low and middle income countries are substantially lower, again due to the deficiencies in access to diagnosis and treatment. So finally, I think what you mean by an integrated cancer registration, to me, an integrated cancer registration is using the cancer registry data to monitor, evaluate, and alter the course of cancer control measures. And to do that, you don't need to cover the entire country. For Thailand, the current Sentinel registration is excellent. You have data from north, east, south, west, and central. And you people are constantly trying to improve the quality of the data. I appreciate that because this is one country where, Dr. Sulipon is in the audience. I've seen the efforts they take, not only within Thailand to improve cancer registration, in regional countries like Myanmar, Indonesia, Vietnam, Laos, Cambodia, and all those places. Okay? But as usual, in many places, the application of the data, the availability of the data for researchers have to be improved. So it should be easily accessible to researchers and policymakers. There is a lot of efforts in Thailand to publicize the data. The net accessibility of the data has to improve. And in fact, several times I tried to access the Thai data through the internet. I have difficulties in accessing. So this is something which needs to be looked into because you have excellent quality data coming from some of the registries. The integrated data are excellent, which can be very useful for many Thai researchers and other researchers to know what is really happening in Thailand for cancers such as liver cancer and cervix cancer, breast cancer. And then ultimately, interpretation and application of trends in incidence, survival, and mortality. And in fact, one of the main objectives in cancer control for Thailand in the next 10 years is the ability to introduce human papillomaviral vaccination as part of the national immunization program. I understand this year there has been a considerable debate within the Ministry of Health, and it has been recommended to the National Health Security Office for the possibility of introducing this next year. I don't know where they are at the current situation. And let us hope this will happen because this is one of the cost-effective interventions. The country has the capacity to negotiate at Gavi prices because now one can go and negotiate the prices. It is feasible and 2 doses is all that's sufficient. And along with substantial screening ongoing in this country, whether with VIA or with HPV testing or with cytology, whatever it is, an introduction of HPV vaccination will substantially reduce cervical cancer incidence. At the same time, we should also look into measures of improving breast awareness, physical activity, diet, and all those issues to prevent the rise in breast and colorectal cancer, and then expand the colorectal cancer screening program through the primary health services across Thailand. I think you are very lucky. I mean, I'm not saying this because I'm not biased with the National Cancer Institute or with Thailand. I'm saying this as an independent observer. I think the NCI here has a much more outlook into public health than many of the traditional cancer centers. And you have people like Dr. Kobchitt and many enlightened people, Dr. Pisak, many people, I'm just saying few names. There are a lot of people, there are many regional leaders. So the country is at the verge of, for a leap in cancer control, provided some of these measures are taken into right earnest and then they are applied. So this could be a role model for other Asian countries in the region. Thank you.
Microphone there doesn't work. Does it work now? Okay. Microphone there doesn't work, but I want to thank both the speaker. You all have the question, I know, but I will ask the two speakers coming up after I try to conclude this in the last 2 hours, that 1.5 hours that we've been talking. No, ไม่ใช่ พระอาจารย์อยู่ไหนอะปิดก่อน trying to find my slideเปิดอันใหญ่May I speak in Thai right now แล้วเอาใหญ่อยู่ไหนฮะเราฟังกันมาแล้วตั้งแต่ดร. สเมลเลอร์แล้วก็ตั้งแต่คุณสังขะได้พูดมากเลยเกี่ยวกับเรื่องของ cervical cancer control และก็ cancer อื่นๆสิ่งเหล่านี้ก็คือ equity ของการทำงานนะคะอะไรคือ equity เราดู burden ของ cancer ดิฉันจะพูดในฐานะเรื่องของ cervical cancer นะคะ cervical cancer เนี่ยมันมี burden และมันมี equity ในเรื่องของการ control เราจะทำยังไงที่จะทำเรื่องของ comprehensive ได้ยินที่ดร. สังขะพูดแล้วใช่ไหมคะว่าถ้าจะให้มี good statistic เนี่ยมันจะต้องมีตั้งแต่เกิดขึ้นกี่รายหลังจากเกิดขึ้นกี่รายเขาทำยังไงมี intervention อะไรซึ่งน้อยนักเลยของเราที่จะพาไปถึง intervention เวลาที่ดูเคสเข้าจริงๆไม่มีมากเท่าไหร่เลยนะคะอันนี้ก็คงจะเห็นแล้วว่า cervical cancer อันเนี้ยในประเทศไทยของเราก็ยังมีเยอะอยู่25ประมาณ25นะคะสไลด์นี้มันจะไปซ้ำกับที่สิ่งที่พูดมาแล้วอยากให้ดูสไลด์อันนี้ค่ะเห็นไหมคะว่าทุกอย่างเหมือนกันลงนะไชน่าอินเดียญี่ปุ่นฟิลิปปินส์สิงคโปร์ไทยแลนด์แต่ดูดีๆนะคะของไทยแลนด์นะลงจริงจากเท่าไหร่30กว่าขึ้นไป3อันนี้ต่อแสนนะคะแล้วลงมาเหลือประมาณ22ต่อแสนซึ่งมันไม่ได้ลงเลยอันนั้นก็คือสิ่งที่เรากำลังเผชิญกันอยู่ว่าเราทำอะไรทำไมมันถึงไม่ลงนะคะเราพยายามทำกันมากมายก็จริงในเรื่องของการสกรีนนิ่งนะคะอันถัดมาจะให้เห็นว่ามี inequity ในแต่ละจังหวัดต่างๆในแต่ละภาคนะคะอยากจะให้ดูอันล่างเลยอันล่างเนี่ยชี้ตรงไหนล่ะอันเนี้ยนี่ค่ะอันนี้นี่คือสุราษฎร์ธานีอันล่างเนี่ยนะคะสุราษฎร์ธานีนี่ทำมาตั้งแต่ทำ cervical cancer ขณะนี้เหลือประมาณ12ต่อแสนซึ่งถือว่าดีมากอันที่ยาวมีมากที่สุดขณะนี้คือจังหวัดลำพูนในประเทศไทยแม้กระทั่งequity ในประเทศเดียวกันมันก็ยังไม่เหมือนกันเพราะฉะนั้นสิ่งที่เราควรจะต้องพยายามในฐานะที่เป็นpublic health personnel ในฐานะที่เป็นผู้บริหารเนี่ยควรจะต้องคิดถึงเรื่องนี้ว่าเราจะทำยังไงให้คนทั่วประเทศได้รับการดูแลอย่างทั่วถึงเหมือนกันนะคะลพบุรีก็เยอะนะคะกรุงเทพเองในฐานะที่เป็นเมืองหลวงการทำงานก็มีแต่ทั้งหมดเนี่ยอย่างที่ดร. สังขะได้พูดมันเป็น opportunistic screening ถ้าเขามีความสามารถไปพบแพทย์โอเคเราสิ่งที่ควรจะทำคือควรจะ organize จับคนไข้ไปเลยหลังจากที่ได้ทำpositive พยาบาลพาไปที่โรงพยาบาลไปทำการรักษาต่ออันนั้นคือสิ่งที่เราเนี่ยควรจะต้องทำมันจะได้มี intervention เพราะว่าถ้าทำ screening เนี่ยมันเป็นสิ่งที่จะช่วยเรานะคะก็จะมี equity in health and health system ดู geographic นะคะนี้สิ่งถัดมาทำไมมันไม่ไปล่ะ Comprehensive approach ก็คือต้องมี community education ซึ่งในจังหวัด101เนี่ยเท่าที่ดิฉันเห็นเนี่ยถ้าน่าจะเป็นตัวอย่างให้จังหวัดอื่นอสม.ที่นี่ดีมากไปอธิบายให้ฟังนะคะทุกคนคงได้หนังสือที่อยู่ในเล่มที่เป็นหนังสือของ WHO ที่แปลกันออกมาสำหรับเนี่ยนะคะหน้าปกก็เป็นหน้าปกเป็นรูปของผู้หญิงที่มาตรวจแล้วผู้หญิงที่มาตรวจส่วนใหญ่นะ บางทีเป็นอสมซะทั้งหมดเลยที่เข้ามาช่วยแล้วพอเขาตรวจเสร็จแล้วเขาก็กลับอธิบายให้ผู้คนฟังนะฮะมี social mobilization แล้วเราก็ควรจะต้องมี vaccination นะคะเราก็หวังว่า vaccination ของประเทศเราเนี่ยก็คงจะได้ใน Gavi price I don't know how much Gavi price is it they're still high in this country 6,000 baht for 3 dosesเราต้องมี treatment คือการ refer ต่อนะคะและมี palliative care ก็การที่จะ prevent มะเร็งปากมดลูกได้มันก็ควรจะมีappropriate test มันไม่พอหรอก appropriate test แล้วมันควรจะต้องมี organized approach good screening coverage คำว่า coverage นี่อีกเหมือนกันไม่ใช่ opportunistic ใครเดินมาก็ได้ตรวจใครเดินไปก็ได้ตรวจไม่ใช่อย่างนั้นจะต้องรู้ว่า age ในกลุ่มที่ high risk ก็คือ 30-49 นะคะ management ของ screen positive ทำยังไงซึ่งใน101นี้ก็ทำได้ดีนะคะแล้วก็การที่เอาคนไข้ไปรักษาก็ไม่ได้แพงอะไรนะฮะทีนี้เดี๋ยวอยากจะผ่านไปจนถึงตรงนี้ criteria สำหรับอายุแล้วก็ความถี่ห่างของการสกรีนเนี่ยก็ควรจะต้องมีนะฮะผู้หญิงอายุ30 ปีก็ควรจะได้รับการตรวจนะคะแล้วก็อย่างน้อยๆก็ทุกๆ5 ปีนะคะแล้วก็ดูว่ามีใน area ที่มันมี HIV infection เนี่ยก็ควรจะได้รับการสกรีนแล้วก็ได้รับการทรีตนะฮะดังนั้นอย่างที่ทั้งสปีกเกอร์ทั้ง2 คนได้พูดมาแล้วเนี่ย HPV วัคซีนนั้นสำคัญเราจะ prevent next generation ของผู้เด็กในบ้านเราคิดถึงตัวเราเองขณะนี้เนี่ยควรจะคิดถึงผู้หญิงที่อายุ 30-49 ในประเทศไทยขณะนี้มีประมาณ15 ล้านคนได้รับการตรวจไปประมาณ2 ล้านอย่างมากลองนึกดูกันแล้วกันที่เหลืออีก10 กว่าล้านคนน่าจะทำอย่างไรเราในฐานะเราเป็นแพทย์เป็นพยาบาลเนี่ยช่วยเขาได้ไหมก็หวังว่าคนรุ่นใหม่ในอนาคตเนี่ยคงจะได้ทำขึ้นมานะฮะวิธีการตรวจก็มี3 วิธีอย่างที่ดร. สเมลเลอร์ได้พูดนะคะ conventional cytology อันนี้รีวิวมาจากดร. สังขะแหละแล้วก็ HPV DNA test แล้วก็ visual inspection อะไรก็ตามที่ทำให้คนไข้มาแล้วได้รับการตรวจได้รับการรักษาถ้ามีอะไรผิดปกติม้วนเดียวจบเขากลับบ้านไปไม่ใช่มาแล้วก็ยังบอกว่าไม่รู้แล้วต้องกลับมาอีกคนหนึ่งอันนั้นเป็นอันที่เราจะเกิดปัญหาในการที่มีเคสมากขึ้นนะคะ แต่ดิฉันก็คิดว่าเดี๋ยวมีสไลด์อีก2-3ดิฉันอยากจะยกคำพูดของเซอร์มาลมอดซึ่งได้รางวัลพระบาทสมเด็จพระเจ้าอยู่หัว Prince Mahidol Award เมื่อปีที่แล้วนะคะเขาบอกว่ามี6 policy recommendation ที่เกี่ยวข้องกับว่าเด็กทุกคนเนี่ย every child จะต้องมี best start in life แล้ว all children เนี่ยก็คงจะต้องมี control over their life มีmaximize their capacity and have control over their own life create important employment good work ensure healthy standard of living นะคะ create and develop healthy and sustainable place for and community strengthen the role and impact of ill health prevention มีอะไรก็ควรจะต้องรู้นะคะแล้วก็จริงๆเนี่ยอันสุดท้ายคำพูดอันนี้ดิฉันชอบมากเลยทำซะเหอะจะทำอะไรก็ทำก็แล้วแต่ทำมากขึ้นนะคะแล้วก็ทำให้มันดีขึ้นไม่ใช่ดีแต่พูดนะคะซึ่งอันนี้นี่อยากจะฝากรุ่นหลังทุกคนไว้เลยนะคะไม่ใช่บอกไม่มี pathologist ทำอย่างอื่นไม่ได้ไม่มี cytologist ทำอย่างอื่นไม่ได้ไม่อย่างนั้นไม่ควรมันก็ไม่เกิดประโยชน์อะไรขึ้นทำอะไรก็ได้ยังดีกว่าไม่ทำเลยนะคะอันนี้ก็อยากจะฝากไว้สรุปอย่างนี้นะคะ so next I would like to call the 2 speakers come up here please so and if you have any question you can come to the microphone tell who you are and then ask the question you want please come up here
ชิญนะครับท่านไหนที่มีคำถามนะครับมีข้ออยากจะขออธิบายเพิ่มเติมนะครับสามารถเชิญได้เลยครับ
Okay.
First, I have to apologize that I come to the meeting a little bit late. I didn't listen all of your talk, but I just want to share something. My name is Mr. Khunying, a lecturer from Biology Department, Faculty of Science, Mahasakam University. I used to be interested in cancer because I studied genetics from University of Wisconsin Madison long time ago. I graduated in 1997. About almost 20 so years now. From my part, I just want to speak on behalf of the Thai people. Cancer is still, I agree that it's still the leading cause of death, as you know. But if I speak it frankly, I think it's good to train scientists, doctor, nurse, or some kind of human resources to be ready for cancer patients. But still, this is very difficult. First, our human resource is not that very great anymore. This is the fact. The students not that very hard study or very diligent. They may spend some time on Facebook, Line, telephone, or so many things. And at present, we are in the aging society like Japan. Japan, many people getting old. The same thing happen in the US also. The longer you live, the longer you have to have burden some on having people to take care of the elder. For myself, my mother retired from Mahasakam University, and she needs to pay for someone to take care of her all the time because she's disabled after some kind of unexpected crime. I don't want to say in detail, but myself, 42 years old, I'm in the middle age. I'm lucky that I don't have family. I don't have a wife or children like my friend. My friend maybe have wife, children, and they have also parents to take care, and their parents retire, cannot work, and you know, this is the very important issue to aware of aging society. What concern about cancer? Like Dr. Jalas Suwanawala said that mission impossible. You think it's impossible for cancer treatment? I think it's still impossible, mission impossible in Thailand. Even though you can study sorts of many knowledge, but I think if we have to die, we have to die. And we still have problem with budget. You see, 30 baht kill all disease. They will not cover cancer or other kind of thing. Even though I'm an officer, royal government officer, the government can pay for my sickness in the hospital, in the public hospital. But I think for cancer, I have to pay by myself, and it costs a lot too. I agree that I'm not that very rich, because most of the government officers, they don't have high salary. This is a real problem for Thai country. And if you see the folk, the local people, they're still even poorer than I am. And cancer still mission impossible. And your facility, the mobile unit or something that you want to prove cancer is not the one solution to help with cancer. I still believe that preventive measure is more important than curative measure. Even if you want to cure somebody who already get cancer, it's very, very difficult. But prevention still possible. For myself, I'm not that very old. I cannot tell how to take care of myself that I'm still healthy. I come here with a walking stick. I am still very
It was not a priority for them, and it's not required in the majority of our states. So now we have a very active campaign by the U.S. NCI-designated cancer centers to really push the vaccine and talk about, as cancer providers, how important this is. And the government has asked us to do that because they said at least in the U.S., the people are tired of hearing it from the government, but if they hear it from cancer experts, it has a little bit of a different message. So we are trying that campaign now. We have a big campaign next month as the kids go back to school about vaccination, and the cancer centers are involved. But I think from the beginning, to have groups like yourselves really promoting the vaccine, I think is also a good strategy. On the subject of health disparities, the HPV vaccine has been very interesting in the US because our minority populations have higher vaccination rates than our Caucasian white population. And we have never seen that for other vaccines because our minority populations tend to have lower access, lower socioeconomic status, and lower access in general. So they have lower rates of hepatitis, vaccine, et cetera. And for the HPV vaccine, it's been higher. And I think one of the things is that we have such a success story in the US about cervical cancer because our rates are low that most people don't know someone with cervical cancer. But for our immigrant populations from Latin America especially, and our poorer populations, they have a sister or an aunt or a mother that had cervical cancer. So the idea of a vaccine to prevent it is very interesting. So it has been a story, the studies are small, but it's been a very different story that our minority populations have equal or better vaccination rates for HPV.
Thank you. I have a group example of a small cohort of 4,000 girls age 9 to 13 that we did in one of the province, and we plan to follow it in 10 years when they grow up. We don't know yet the result, but after the first dose, we have 99% come back because this is the organized one we follow through. And the second dose is 99% too. We lost just only very minimal. So it's not only to give the vaccine. It's not like the immunization. It's a cold chain, and it's everything that you have to train the one who give the vaccine. So, yes, sir, please.
I think, Kathleen, you made a very important point. It has been universally now shown wherever the vaccine has been pushed through the clinic, it has failed. In Bhutan, it started as a school program, then they switched over to clinic-based. The third dose coverage went down to 55%. They switched over to school-based. It went up again. So all countries now use predominantly a school-based approach. And the second point is, now I wouldn't say for a public program, HPV vaccine is no longer expensive because we have such a negotiating power at the moment. Many countries can now go and negotiate, no, give us the Gavi price. The Gavi price is $4.99 US.
$4.99.
So $5. So which we are talking about something like 160 baht per dose. In Latin America, the PAHO revolving fund was purchasing at a rate of $16 per dose. And then they went and said, oh, we need the Gavi price. Since these countries have a per capita GDP like 10 to 16,000 US dollar, finally they settled down a price of $8 US per dose. So many of the developing countries with a, who really want to vaccinate, now it is possible to purchase vaccine at considerably lower prices. And this will further go down because the Chinese vaccine is, likely to be in the market very soon because they are already undergoing phase 3. But the Chinese regulator is saying, oh, we need information at the level of CIN3. And another important development is the NCI-IARC Joint Working Party came out with a consensus for future vaccines or future doses. We need not wait until CIN3. Persistent infection could be an endpoint so that the new vaccines can come out or new dose schedules can come out much more faster for regulatory approval.
So I think almost the end. So I asked the
Yeah, we got about 5 minutes left.
what is going to be next?
So right now it's about like 3:55, and at around 6 o'clock we're gonna be have dinner reception. So is there มีท่านไหนอยากจะขอแถมอีกสักคำถามไหมครับ
ไม่มีก็ไม่เป็นไร
โอเค
ค่ะ
นะครับในโอกาสนี้นะครับต้องขอกราบขอบพระคุณนะครับท่านวิทยากรทั้งสองท่านมากๆนะครับ From now I would like to express the appreciation to the guest speakers Dr. Kathleen Miller and Dr. Sankha for their insight, for their experience, their knowledge to share with us today. And for next, I would like to ask Dr. Khunying Kobchitt to present the gift of appreciation to our guest speakers.
Token of appreciation.
เดี๋ยวขอเชิญท่านอาจารย์มอบของที่ระลึกให้กับวิทยากรนะครับ เชิญเลยครับ ด้านบนครับ Thank you very much.แล้วก็ขอกราบเรียนเชิญนะครับท่านนายแพทย์เกรียงไกร โกวิชางกูลนะครับจากบนเวทีเพื่อมอบของที่ระลึกให้กับท่านอาจารย์แพทย์หญิงคุณหญิงกอบจิต ลิมปพยอมนะครับ นะครับแล้วก็ขออนุญาตนะครับถ่ายภาพหมู่ร่วมกันนะครับอีกครั้งหนึ่งครับซึ่งซิมโพเซียมในบ่ายวันนี้นะครับก็ถือว่าเป็นกิจกรรมนะครับซึ่งให้สาระได้ความรู้นะครับเป็นอย่างยิ่งนะครับซึ่งทำให้เราได้รับความรู้ข้อมูลดีๆใหม่ๆนะครับจากต่างประเทศนะครับแล้วก็จากวิทยากรผู้ทรงความรู้นะครับนำเอาขอบพระคุณมากครับนำเอาข้อมูลนะครับสิ่งหลายๆอย่างนะครับเพื่อที่จะนำเอาไปใช้ในงานการทำงานนะครับในบริการท่านทางด้านการแพทย์และสาธารณสุขนะครับแล้วก็ในโอกาสนี้นะครับก็ต้องขอกราบขอบคุณนะครับท่านผู้ชมทุกท่านนะครับต้องขอขอบคุณนะครับท่านผู้ร่วมรับฟังทุกท่านนะครับที่ได้ให้เกียรตินะครับมานั่งรับฟังในซิมโพเซียมดิสคัชชั่นบ่ายนี้นะครับแล้วก็สำหรับกิจกรรมนะครับต่อไปนะครับจะเริ่มต้นเวลา 6 โมงเย็นนะครับ 18 นาฬิกานะครับจะเป็นdinner reception นะครับตรงที่หอประชุมที่นี่ที่เดิมนะครับในช่วงนี้นะครับก็ท่านสามารถพักผ่อนตามอัธยาศัยนะครับต้องขอกราบขอบพระคุณอีกครั้งหนึ่งครับขอบคุณมากครับ